vast experience and insight to this subject. And we want to encourage active participation through questions and comments. And these ones you can just type on the chat box, and we shall read them at the tail end of the presentation. So our today's speaker is Agri Nyaboga, and Agri is a dedicated medical lab scientist, and he holds a Bachelor of Science in Medical Lab Sciences and currently pursuing an MSc from the University of York, UK. So Agri also boasts of successfully completing the IBMS portfolio. And truly this is a testament to his commitment to global standards in lab practice. So Agri, if you can hear me, you can unmute and say hi.
Hi, Fred, I can hear you clearly. I hope you can hear me too. Hello, I hope you can hear me too.
Yes, I can hear you, Agri. You can proceed.
Okay.
Your screen is not shared.
Thank you. Yes, thank you. Thank you, Fred, for that invitation and introduction. I really appreciate this platform. Let's learn together. Today, we are going to look at megaloblastic anemia and specifically the clinical laboratory approach to diagnosis and management of the same. So megaloblastic anemia is a very important disease that require urgent attention and attention with clarity, so that it's not overlooked as a simple condition, and patients suffer without being treated with urgency they need in order to manage the condition. It might appear simple as it looks. However, it can bring complexities and even fatalities in life, or serious disabilities in life, as we look in the coming slides in the course of the webinar. So in definition, megaloblastic anemia is a type of anemia that's characterized by the production of abnormally large red cells that are not able to function properly. Megaloblastic, as the name dictates, mega means larger, and the blastic is talking about cells, cell production. The causes of megaloblastic anemia are varied. Among others are vitamin B12 deficiency and also folic acid deficiency. It can be inherited, and also certain medications can also cause vitamin B12 or folate deficiencies. Clinical features will include fatigue, weakness, pallor, shortness of breath, and neurological symptoms. These are among other clinical features that these are majorly expressed or manifested in megaloblastic anemia. Causes of vitamin B12 and folate deficiency are like causes of folate deficiency. We have dietary deficiency, and this is due to inadequate intake of folate-rich foods. Folate-rich foods are, for example, leafy vegetables, the greens, citrus fruits, and many others. But majorly, green leafy fruits and green leafy vegetables and also fruits are the major contributors to dietary sources of folate or folic acid. Another cause is malabsorption, especially in conditions like celiac disease and Crohn's disease and ulcerative colitis. Increased demand can lead to deficiency, especially in pregnancy, lactation, and rapid growth period. Medications can also cause folate deficiency, such as anticonvulsants, sulfasalazine, and also methotrexate. Methotrexate is usually used in cancer therapy. It's a chemotherapeutic agent, of anticonvulsants, like in treatment of epilepsy and other neurological symptoms. Alcoholism is another cause of folate deficiencies, especially chronic alcohol consumption. We have also folate antagonists and certain chemotherapeutic agents in addition to methotrexate. Causes of vitamin B12 deficiencies. Vitamin B12 deficiencies can also be as a result of dietary deficiencies, especially in adequate intake of animal products, e.g. meat, fish, and dairy. Malabsorption conditions like pernicious anemia can also cause vitamin B12 deficiency, also celiac disease and Crohn's disease. Pernicious anemia is an autoimmune condition whereby there is destruction of parietal cells in the gut, and these parietal cells are usually they usually have the intrinsic factor. They produce the intrinsic factor which aids in absorption of vitamin B12. So if these cells are destroyed, that means that vitamin B12 is unable to be absorbed. That's basically what pernicious anemia entails. Gastric or intestinal surgery will lead to a decreased intrinsic factor production or malabsorption. Medications such as proton pump inhibitors, H2 blockers, and metformin are also major causes of vitamin B12 in vitamin B12 deficiencies. Others are like infections like Helicobacter pylori or fish tapeworm. Fish tapeworm, in another term, it's called Diphyllobothrium latum in parasitology. We're going to look at pathophysiology of megaloblastic anemia. Megaloblastic anemia is caused by impaired DNA synthesis in rapidly dividing cells, particularly in the bone marrow. The key factors are vitamin B12 or folate deficiency leads to impaired DNA synthesis due to lack of coenzymes. And we are going to talk about those two, the coenzyme that's majorly involved, and that is thymidine. Thymidine is a key coenzyme in DNA. There is impaired thymidine synthesis. And this impaired synthesis of thymidine, it leads to lack of thymidine or considerable deficiency in thymidine. This leads to misincorporation of uracil. So we're going to look at this, what this means, that there is lack of thymidine synthesis. So during the cell cycle, thymidine is not available in the cell cycle, especially the S phase. During the S phase, the cell is rapidly replicating, and it needs a lot of thymidine for proper replication to occur. But when the cell processes realize that there is absence of thymidine, there is a replacement of uracil. uracil is replaced, and uracil is not normally required. It's not normally required in replication stage, but it's replaced so that the cell can sustain its replication, however, temporarily. So this leads to disrupted DNA replication and cell division, and therefore causes abnormal cell maturation and asynchronous nuclear and cytoplasmic maturation. Asynchronous means that they don't move in tandem to the pattern that they are required of. You find that the nucleus mature late, and the cytoplasmic maturation. Okay, the cytoplasmic maturation is okay, but nuclear maturation delays. So this is a cell cycle that we're talking about. So there is uracil misincorporation in megaloblastic anemia. You see, during the S phase, where we have DNA replication, there is lack of thymidine, and this leads to replacement of thymidine with uracil. And there are usually serious consequences of this misincorporation, as we look, as we'll examine later in the webinar. Consequences of uracil misincorporation. The presence of uracil in DNA is abnormal and leads to serious problems in rapidly dividing cells, particularly in the bone marrow. DNA damage and repair during these processes. Uracil is misincorporated into the cells so that the process can continue. Now, what this leads to is genomic instability and apoptosis, because the overwhelming misincorporation of uracil because of absence of thymidine will lead to subsequent repairs, because uracil is not needed in that stage. When it's temporarily replaced, later on it has to be corrected. That error has to be corrected. Because of this correction and subsequent absences of thymidine can lead to detection of abnormal cells, and these abnormal cells have to be eliminated altogether. So these cells are programmed to die because they are deficient, they are inefficient cells, and they are meant to be destroyed because they are not significant in normal cellular processes or normal physiology in human body. This extensive DNA damage triggers cell destruction mechanism. That's what we call apoptosis, particularly in red cells, precursors, especially the erythroblasts, in the S phase of the cell cycle. So the consequences of uracil misincorporation continue. This one leads to ineffective hematopoiesis. There is premature cell death of these developing blood cells in the bone marrow, a condition called ineffective erythropoiesis. This results in production of fewer but abnormally large and immature red cells. Those are usually called macrocytes. So this process goes this way, that there are so many cells that are being produced from the bone marrow. But these cells, because of the abnormality of uracil misincorporation, these cells are programmed to die in a process called apoptosis. And you will find that the cells that there are some few cells that miss the process of apoptosis. They remain in the bone marrow because they don't mature. They are abnormal cells and they don't mature. So the bone marrow is constantly active, and it becomes hypercellular. Overall, this process explains the key features of megaloblastic anemia, because we'll find later on that the bone marrow, when we evaluate the bone marrow, is usually hypercellular. While this is in deep contrast with the peripheral blood, where we find megaloblasts with pancytopenia, whereby we have macrocytosis and hypersegmented neutrophils due to the asynchronous maturation between the nucleus, where because of the impaired DNA synthesis, and the cytoplasm, whereby we have an affected RNA and protein synthesis. So there are two issues here. About this asynchrony, especially in maturation. The cytoplasm is usually unaffected. The cytoplasm matures, leaving behind the nucleus. Now, following now what we understand, especially in hematopoiesis, when the nucleus is immature, it is usually large and covers a large portion, a very big percentage of the cell. But when there is when the cell matures, the nucleus becomes condensed because of the condensation of also the nuclear material, and it becomes smaller. So you find that these cells, when we look at them, especially in the peripheral blood, they are cells with a very large nucleus and a little with a small portion of the cytoplasm. We're also going to look at differential diagnosis of macrocytic anemia. There are two types of macrocytic anemias or megaloblastic anemias. There are two categories, and these are the factors that can lead us to have a differential diagnosis, to distinguish between the two, or the origin of the cause of the megaloblastic anemia. So there is true megaloblastic anemia, and there is non-megaloblastic anemia. Megaloblastic anemia, which is of the topic today, can be diagnosed through vitamin B12 deficiency, folate deficiency, and also can be as a result of drug and induced anemia. However, this is different from non-megaloblastic anemia, which can result from excess alcoholism or excess alcoholic consumption, liver disease, hypothyroidism, aplastic anemia, paraproteinemia or myeloma, pregnancy, and neonatal period. So we continue with the differential diagnosis of megaloblastic anemia. So when there is a clinical indication that we have a megaloblastic anemia or macrocytic anemia, this is the algorithm that we can follow, especially if we want to differentially diagnose this condition. The hemogram will show low HB, and MCV will be greater than 95. The reticulocytes are also evaluated. If they're increased, this will lead us to highly suspect hemolysis or blood loss. However, if the reticulocytes remain normal, now this is whereby we will have high suspicion index, that is megaloblastic anemia, with the MCV of greater than 115. 115 femtoliters. And this is likely to be either folate deficiency or vitamin B12 deficiency. Now, when it's not so much raised, especially the MCV, if it's not so much raised, we will suspect hypothyroidism, liver disease, alcohol use, Down syndrome, drugs, or early folate or vitamin B12 deficiency. So here we can clearly be able to differentiate between megaloblastic anemia and what we are talking about, the non-megaloblastic anemia, with a little bit different causes altogether. So if all these are excluded, the condition is likely to be myelodysplastic, myelodysplasia or myelodysplastic syndrome. Laboratory findings, especially in complete blood count, macrocytic anemia is usually of greater than 100 femtoliters, indicating larger than normal red cells. This is a hallmark of megaloblastic anemia. But now, in differential diagnosis, we will look at how raised is the MCV, to what extent, and will this inform us early folate or vitamin B12 deficiency, or is an indication of a non-megaloblastic condition, which is associated with the hypothyroidism, liver disease, alcohol use, Down syndrome, drugs, etc., etc. So this helps us to be able to do the differential diagnosis. So when we have low hemoglobin and hematocrit, this usually confirm anemia, which can be severe in some cases. Leukopenia or erythropenia also can be suggestive of bone marrow suppression, which can occur in megaloblastic anemia. Peripheral blood film findings, we have macroovalocytes, large oval-shaped red cells are characteristics of megaloblastic anemia. They are usually hypersegmented neutrophils with greater than 5 lobes. In greater than 5% of neutrophils are counted in the peripheral blood film. And this is a specific indicator of megaloblastic anemia. So this is a specific finding and also a specific indicator of megaloblastic anemia. There is also anisocytosis and also poikilocytosis. Anisocytosis is different cell sizes, especially the red blood cells, and poikilocytosis means different cell shapes, different RBC cell shapes, cell shapes. Variation in red cell size and shape indicates disordered erythropoiesis. There is also basophilic stippling in this condition. Now, this is the peripheral blood picture. We can see those microovalocytosis. You see those oval cells, the red blood cells are oval, and also they are large as compared to the normocytes that you can see there. We have also that hypersegmented neutrophils. You see, neutrophils you'll have less, 4 or less, mainly 4 or less, sometimes 5. But when we find, in hypersegmented neutrophil, in neutrophils, the segmented neutrophils are usually 4 lobes and below. But when we find 5 segments and above, it's usually an indicator of even a serious infection, but now it's a common indicator of megaloblastic anemia, especially when we also see macrovalocytes as indicated there in that field. So when you see this kind of hypersegmented neutrophils, also look for macrovalocytes. If they are present, and that one will be a confirmation of macrocytic anemia or megaloblastic anemia. Yes, this is also a schematic presentation of hypersegmented neutrophils. You can see them. Yes, you can see normal neutrophils with the three lobules and the normal size, the normocytes. That's the normal red blood cell. You can see the difference between that and also the megaloblastic anemic cells. You can see how many lobes that cell has, that neutrophil has. It has 11 lobes. That's considerable hypersegmentation. This is a picture of the bone marrow. The bone marrow is hypercellular. You can see the difference between that normal bone marrow and also the megaloblastic bone marrow. Interpretation of these findings, the presence of macrovalocytes and hypersegmented neutrophils is a highly suggestive of megaloblastic anemia. CBC and peripheral blood film findings combined with clinical features and other laboratory tests, e.g. vitamin B12 and folate levels, help to establish the diagnosis. So if you see the 2 points, point 1 and 2, the presence of macrovalocytes and hypersegmented neutrophils, this will inform us that the next thing that we should evaluate is vitamin B12 and folic acid, so that our diagnosis is established. Of course, that follows with other clinical findings. These findings contribute to diagnosis by confirming anemia, the megaloblastic anemia, and its severity. We identify the characteristic morphological changes in red cells and neutrophils, guiding further testing and treatment decisions also. So the algorithm for diagnosis, we have CBC and peripheral blood film. That is first. And secondly, we have serum B12, vitamin B12 and folic acid levels. There's also the third element is serum homocysteine and methylmalonic acid levels, that's MMA, if vitamin B12 deficiency is suspected. We are going to see how MMA is very important in differential diagnosis of megaloblastic anemia. We also check the intrinsic factor antibody tests if pernicious anemia is suspected. We are going to move deeper into differential diagnosis. In folate deficiencies, MLA, methylmalonic acid, levels are typically normal. That's in folate deficiency. Methylmalonic acid is normal, while homocysteine levels are elevated. This pattern helps to distinguish it from vitamin B12 deficiency, where both MMA and homocysteine rise because B12 is crucial for MMA metabolism. So if you see high homocysteine but normal MMA, it strongly points to folate deficiency. It's very important for us to differentiate between the two because of treatment. Because one cannot be given vitamin B12 when this person has folic acid deficiency. This patient will continue suffering from folic acid deficiency and later on develop complications. Sometimes combination of folic acid and vitamin B12 approach can be sometimes be expensive for no good reason. Yeah, so it's very important for us to do a differential diagnosis before treatment begins. It can occur that way or vice versa. One can be given folic acid when this person has vitamin B12 deficiency. It does not help either. Also, diet prescription, okay, that means dietary advice or yes, one can be given a wrong advice for a wrong condition. So this is why it's important for us to do differential diagnosis before treatment and management starts. There are key distinctions in deficiency tests. For instance, when we have folic acid deficiencies, we are still in differential diagnosis. In folate deficiency, we have elevated homocysteine, normal MMA, and low folate. Those are three key issues, key distinguishing features of folate deficiency. In differential diagnosis, we are going to look at vitamin B12 deficiencies. How do we differentiate between B12 and folate? As we've seen previously, folate deficiencies, we have elevated homocysteine and normal MMA and low folate. But vitamin B12, we have elevated homocysteine and elevated MMA and low vitamin B12. Obviously, vitamin B12 is low vitamin B12, but now we come to the two, elevated homocysteine and elevated MMA. So the differentiating feature of vitamin B12 and folic acid deficiency is the element itself, folic acid or vitamin B12. But the key differentiating feature, which is common among the two, is methylmalonic acid, that is MMA, as we've seen in those two. Okay. Now we have a case study. For example, a patient with megaloblastic anemia where we have CBC results indicating microcytic anemia, low hemoglobin, and hematocrit, low hematocrit. The peripheral blood smear shows macrovalocytes and hypersegmented neutrophils. And when you look at in the biochemical picture, we have serum vitamin B12, which is low, elevated MMA, and this one will show us that's typically vitamin B12 deficiency. So when we have low MMA and low folic acid, it will be an indication of folic acid deficiency. So next we are going to look at common complications associated with deficiencies, both folate and vitamin B12. These deficiencies will lead to megaloblastic anemia, where red cells become large and ineffective, causing extreme fatigue, weakness, and shortness of breath, and also pale skin. We have also cognitive issues, difficulty concentrating, memory loss, confusion, and poor judgment. So you can see how important the two are, especially in cognitive issues, learning and learning disability, learning ability and learning disability. So there is something that it informs here, it informs that can inform us here. There are childhood problems that can occur, especially in developing babies, developing children, especially when they lack folic acid and vitamin B12. Psychological problems that includes depression, anxiety, irritability, and mood changes. Yeah, this is common, especially in pregnancy or postpartum periods where there is increased need of folic acid and increased need of vitamin B12 because of lactation and because of developing the developing baby, the developing fetus. I think you've heard of what we call postpartum depression. This can cause postpartum depression, and also general even depression during pregnancy. Anxiety, irritability, and mood changes. These are symptoms that occur in these deficiencies. So it's key that the issue is detected early, diagnosed early, and managed early to avoid this, because later on, if these clinical features are recognized and we don't handle the issue and the baby is born, and there are complications associated with it, like spina bifida, neural tube defects, which are extremely debilitating conditions that should have been prevented earlier. However, nowadays there is a robust system of ensuring that pregnant women receive adequate vitamin B12 and also folic supplementation. There are also gastrointestinal issues. For instance, we have red tongue, also what we call glossitis and mouth ulcers. Glossitis is usually tongue with the lost epithelia. The tongue is very smooth because of loss of epithelial lining. That's called glossitis. And because of loss of this epithelia, the loss of this epithelium can lead to mouth ulcers. So we have vitamin B12 specific complications. This includes severe neurological damage. These pins and needles, there is pins and needles, what we call paresthesia. There's numbness, muscle weakness, and loss of balance. And also we have coordination problems. There are visual issues, potentially irreversible nerve damage, and peripheral neuropathy. You see, such complications are severe. Later on in life, such can cause also infertility and can cause temporary infertility. Increased cancer risk also. High risk of stomach cancer, especially with pernicious anemia. Folate-specific dangers or complications include pregnancy complications, usually high risk of neural tube defects that like spina bifida or anencephaly, the conditions that some of these conditions have stated them in the previous slides. There's also preterm birth and low birth weight. There are long-term complications and severe risks, especially heart conditions. Anemia can trigger strain the heart, potentially leading to heart failure. Autoimmune conditions associated with increased risk of autoimmune disorders like rheumatoid arthritis or Hashimoto's thyroiditis. So in summary, although megaloblastic anemia is considered as a nutritional anemia, megaloblastic anemia is in another sense a hemolytic anemia. Cells die during division. The bone marrow, in the bone marrow, this is also known as intermedullary cell death, causing ineffective erythropoiesis. Reticulocytes in peripheral blood is evidently normal. Signs of hemolysis in serum and increase in both total and indirect bilirubin, as well as lactate dehydrogenase. You see, the two are indicators indirect bilirubin, and bilirubin and lactate are indications of hemolysis. So if these two are elevated, we can suspect megaloblastic anemia. Of course, even hemolytic anemia, in hemolytic anemia, the two are also elevated. But the differential diagnosis with other elements can help us to be able to clearly be able to identify whether it's a megaloblastic anemia or it's a hemolytic anemia. A constellation of other findings, such as marked pancytopenia, macrocytosis, and hypersegmentation of polymorphonuclear neutrophils. Those are neutrophils with neutrophils more than 5 lobes, and basophilic stippling, which is common, and also MCV between 100 and 150 femtoliters. These are key indications of megaloblastic anemia. So it's good for us to have a comprehensive review, for us to diagnose and also differentially diagnose, so that we can clearly get a clear picture on what we are handling. Is it folic acid deficiency? Is it vitamin B12 deficiency? Is the megaloblastic anemia caused by other issues like hypothyroidism? Is it caused by drugs? Is it caused by liver issues or what? So it's good for us to go into detail so that we can have a good differential diagnosis. So I've talked about acids like vitamin B12 and folic acid, which are used especially in monitoring treatment and also for diagnosis, with MMA of a good use in differential diagnosis between B12 and folate. So in conclusion, megaloblastic anemia is a treatable condition that requires prompt diagnosis and also prompt management. Understanding the cause, pathophysiology, and clinical features of megaloblastic anemia can improve patient outcomes and prevent long-term complications, as you've seen in the slides that we have just looked at. So it's important for us to work together to identify and manage megaloblastic anemia effectively. So that's the end of my presentation. Thank you for having me. Maybe I will hand it over back to my senior colleague, Frederick, for moderation so that we can conclude. Thank you, colleagues. Hello? Hello? So as we wait for the moderator, maybe you can welcome questions and answers or points of discussion. As you've realized that megaloblastic anemia is a very important disease that should be looked at with a lot of keenness, so that we'll avoid complications that will follow up, especially after a megaloblastic anemia comes into the picture. Yes, now we'll go to the chat box, and okay. Okay, someone is saying that's Lillian. Can you repeat on the PBF interpretation? Yes, I can. I can repeat. Thank you, Esther. Thank you, Esther, Postina, Calvins. Thank you for the comments. So I can repeat on PBF, PBF analysis and interpretation. Now, there's another question on how does megaloblastic anemia cause spina bifida? Physiology behind it. Thank you. We'll go back to we go back. We'll go back to the PBF analysis of the PBF. Now we'll start. We'll begin with. So in PBF, what we normally look at is macroovalocytes. So there is macroovalocytosis where we have large and oval shaped red blood cells. The second thing that we have to look at when we see those macroovalocytes, maybe either macroovalocytes or hypersegmented neutrophils. With hypersegmented neutrophils, we have more than 5 lobes or more of the neutrophils. So there is hypersegmentation of neutrophils and also macroovalocytes. There are other things that we need to consider also, like basophilic stippling in neutrophils and also poikilocytosis. That's different shapes of red blood cells. We can see different shapes there, yeah, different shapes of RBCs, and also anisocytosis, different cell sizes. Why different cell sizes? Because we have macrocytes and we have microcytes. Also, in PBF, there is also when we do differential counts, absolute counts of cells, whether it's red blood cells or white blood cells, we'll find that there is pancytopenia, and this it will be clearly even be visible in complete blood count. Yes. Now, the peripheral blood film analysis, when we look at these parameters, it will help us to check on the severity of the cases, especially when you look at these morphological findings. You find a marked number of macrovalocytes and also hypersegmentation of hypersegmented neutrophils of more than 6 lobes. Maybe you find some of them are 10, 8, 9, 10, 11. That one shows severity of the megaloblastic anemia, which will also indicate the kind of interventions that will be needed. So this will guide treatment and also the prognosis. How will the progression of treatment be? How is the effectiveness of this treatment according to the stage of or the severity of this condition? So the peripheral blood is very key in identifying these issues. Yes, that's basically what we should look at, especially in peripheral blood film. Then neural tube defects. Folic acid is a very important component in a neurological development. Why? Because of the problem with the DNA, we've checked and seen that what affects these cells is the defects in DNA and DNA metabolism. The DNA is affected because of lack of adequate thymidine, as I explained previously. If there is lack of thymidine in DNA, there is temporary replacement of uracil, and this one enters into the S phase of the cell cycle. This will not only affect the red cells that we are talking about here in megaloblastic anemia, or also neutrophils or segmented neutrophils. It has a far-reaching implication in other cells also, and these cells can be even the neurons. It can be cells of the central nervous system. Those are neurons, which are severely also affected. And this leads to anencephaly. Anencephaly can be either macrocephaly or microcephaly. The same, because it's CNS involvement, it can lead to neural tube defect. So because of the spinal cord, the peripheral nervous system, central and peripheral nervous system is affected. So that informs us why neural tube defects occur, because the nervous system is also involved. The neurons, which are key cells in the central nervous system. So if there is defective DNA, there are also far-reaching effects. I talked about epithelial cell lining of the gut. Now, this one is clearly indicated with glossitis. The clinician will look at the tongue and find that there is no epithelium. Epithelial lining is not there. Epithelial lining is not only defective in the tongue, on the tongue only, but this goes back even deep down to the gut. So there is very poor epithelial formation in the gut. And also there is demyelination of neurons, loss of epithelial lining of the neurons. That case also informs us why there is neural tube defects. Demyelination and the epithelial lining that's defective in the neurons can lead to defects in the central nervous system. Can be in the brain and also in the spinal cord, and that one informs us why we have neural tube defects or spina bifida. I think I've answered that question comprehensively. Let's check for other question. Professor Tom says that folate is required for neural tube development by providing building blocks, DNA stroke RNA, for the rapidly dividing cells, enabling the neural tube, which forms the brain and spinal cord, to close properly in early pregnancy and preventing severe birth defects like spina bifida. Thank you, Tom. He's expounding in details what I was explaining. I have, okay. Thank you, Professor Tom. Let's look for other. Taj Habib, superb talk. Mzuri sana, thank you. Thank you, Taj Habib. Julius Ondiki, The shift to the right of the shift to the right of neutrophils can also be associated with acute bacteria infections. Kindly elaborate. Yes, the shift to the right, that is, we find that there are enlarged. Shift to the right means that there is considerable extreme maturation of neutrophils. Yeah, these neutrophils shift to the right. There is okay. This is okay. Hyperpigmentation shows the shift to the right. I understand you. And it's also associated with acute bacterial infection. Yes, as I was presenting, I talked about even basophilic stippling and also hypersegmentation, which are key indicators of bacterial infection, because the neutrophils have to adjust and also be prepared to ingest the invading bacteria that have been identified have been identified. So what happens? The neutrophils become hyperlobulated to counteract bacterial infection, and also due to this bacterial infection, especially severe bacterial infection, the neutrophils are affected, and what happens is that we have basophilic stippling, which is an indicator that there's an active process of engagement with bacteria. Why are neutrophils hyperlobular? They produce so many lobes so that they can they can be effective in engulfing of bacteria through engulfing of bacteria through as a condition, a mechanism known as I've forgotten, but these lobules play a key role in engulfing of bacteria. That's why they increase in number. That's why they increase in number. On megaloblastic anemia, do we cross-match or for donation, or we correct by giving folate or B12? Now, I think this is a very good question. It gives us considerable point of information. Yeah, we have megaloblastic anemia. The HB is considerably low, and there are issues here that we are dealing with. So there is need for transfusion, especially in considerably low HB. And we can ask ourselves, what can transfusion do? Transfusion will elevate the HB. And also, if this person receives blood, let's assume that this blood is meets the standards. Of course, the blood that is being transfused is well analyzed and also screened for HB and so many other issues. So this blood will be of a great help in improving the condition of this patient. But now, we can also ask ourselves, will that be the solution? And what is the stage of this pregnancy? Is it early stages? Is it late stages? Has it gone too far that we cannot be able to correct? So the issue is the intervention by the clinician. The specialist needs to analyze this and see the best point of intervention. I think this one leaves to experts. Maybe experts here can advise us, those who have handled cases of considerable conditions of megaloblastic anemia. What can we learn from this? I think there is a large pool of expertise here. I think this one can help us, this pool of experts can help us to understand what we can do, especially in cases of severe megaloblastic anemia. And you see, this follows the clinical picture. Also, other diagnostic features like scans can help us to check whether there is macrocephaly, microcephaly, whether there are neural tube defects. Yeah, there's a good scan can show issues with such, and also tests for vitamin B12, folic acid, etc., etc. This one will show us the degree at which the condition has moved or has progressed. Thank you, colleagues. We have Willis Festus. Thanks a lot. Thanks a lot for those comments. Anemia is a common finding in clinical practice, warranting good training, updating, also diagnosis and management. So this CPD is up to the point. Thank you, Professor Tom. Yes, I was talking about phagocytosis. Thank you, Lester, for the same. Yes, the lobules are increased to help in the phagocytosis mechanism. Neutrophils destroy bacteria through phagocytosis. Thank you, Collins. Thank you, Ellie. Beatrice Mulkidia, good work. Thank you, Beatrice. Taj Habib, neutrophils shift to the right is due to megaloblastic anemia. Left shift is for bacterial infection. Oh, yes, thank you, Taj Habib. Phagocytosis is the process of destroying or destructing bacteria. Yes, that's true. Are mastocytes, early retics. Comment if retic count is useful during megaloblastic and after treatment. Now, what we can say about this, about neutrophil count. Neutrophil count can be of help, especially in differential diagnosis. Why differential diagnosis? Mainly, neutrophil, we look at when we look at the immature cells, there's this thing I talked about, reticulocyte count. When you are doing differential diagnosis, we want to differentiate between the hemolytic anemia and also megaloblastic anemia. In megaloblastic anemia, the tick count is usually normal, but in hemolytic anemia, reticulocytes are usually elevated. So elevated reticulocyte count is a key indicator of hemolytic anemias or blood loss. Now, if there is a combination of blood loss and megaloblastic anemia, we are going to look at the nitty-gritties of the picture. That's the blood film and also the complete blood count picture, so that we rule out whether there is hemolytic anemia here, or megaloblastic anemia, or both, the combined picture of the two. Because if we have elevated neutrophils, we have elevated MCH. That's a key. Okay, elevated neutrophils is a key indicator of hemolytic anemia or anemia of blood loss, and elevated MCH is a key indicator of macrocytic anemia. And also, we are going to study to look at the vitamin B12 studies and also folic acid studies. This one will help us to understand the picture that we are dealing with. So it's important for us to do a comprehensive review in complicated cases for us to understand. And this one will warrant us, help the clinicians to know what they are treating and to prevent, so that the disease, the condition can be well managed, and also the prognosis can be well be brought into the picture. So that's why I was talking about a differential diagnosis. So Taj Habib, I hope I've answered you. Reticulocyte is key in differential diagnosis to know what we are dealing with. But in a nutshell, reticulocyte count is normal in megaloblastic anemia. But when we find it high, there is a picture of a mixed issue. It can be maybe due to anemia of blood loss or hemolytic anemia. A shift to the left does it mean that the cells haven't matured? Shift to the left means that cells have not matured. However, when we look at the shift to the left, especially asynchrony in the bone marrow, you remember me talking about the asynchronism in the bone marrow, that the nucleus matures late, and that means it's a shift to the left. And the cytoplasm has already matured. So there is a mixed picture here. There's maturation and late maturation. So in general, shift to the left means immature cells. Thank you, Robert. Thank you, Robert. Did not get you well about transfusion, this type of anemia, and at what levels HB will warrant the transfusion? And do we have cases where this condition may be asymptomatic? Masiga from Eldoret. Thank you, Masiga. As I was saying, this one, okay. I didn't say that that the solution is transfusion. I said that we need more of expertise, knowledge in this, and evaluation about the stage in which the megaloblastic anemia has reached. If the HB warrants transfusion, then transfusion can be the solution. If it doesn't warrant, then why can't we go to move forward to other management issues? Because we have to evaluate, including imaging, the clinical picture, and we have to study the PBFs. We have to look at so many issues, the vitamin B12 deficiency levels, and also folate deficiency levels, for us to be able to determine which kind of intervention is needed. And also transfusion. Transfusion, you know what transfusion means? That is handling a case where the HB has gone too low, and there is need for survival of this patient. How do we handle it? Other management issues will come as the issue presents itself. Julius Ondieki, retic are elevated in all hemolytic anemias due to bone marrow hyperplasia. You are correct. Yes. Thank you, Julius. Points of discussions here are great. I really appreciate. John Wahome, what's the difference between pernicious anemia and megaloblastic anemia? Thank you, John. Pernicious anemia can cause megaloblastic anemia. So pernicious can cause megaloblastic anemia. But pernicious anemia is associated with the intrinsic factor, mostly associated with vitamin B12 absorption in the gut. And what brings about the problem of malabsorption of vitamin B12 in the gut? What is needed for vitamin B12 absorption in the gut is what we call intrinsic factor. And the origin of this intrinsic factor is from parietal cells in the stomach. Parietal cells produce the intrinsic factor, and intrinsic factor is what binds vitamin B12 for absorption. So if there is no vitamin B12, if there is no intrinsic factor, vitamin B12 will never be bound for it to be received by the receptors in the parietal cells. So the parietal cells have receptors, and also they produce the intrinsic factor. So the intrinsic factor binds the vitamin B12 into the receptors, and absorption occurs, and vitamin B12 is internalized and circulates for the body, for the sake of the body's physiology. So if we have pernicious anemia, then it means that there is defective absorption of vitamin B12. And this one definitely will lead to megaloblastic anemia, because we'll have deficiencies in vitamin B12. Definitely to lead to megaloblastic anemia. So thank you, John Warome, for that good question. Nicholas and Amos, thank you. Yes, any other question? Waiting for question. We still have some little time. Intrinsic factor. What causes lack of ineffective intrinsic factor? Now, when we look at the intrinsic factor, which helps in binding of vitamin B12 for it to be absorbed, what makes it to have loss of function? So these are very good question that we should. There are some unique cases whereby we have ineffective intrinsic factor, and this one leads to ineffective absorption of vitamin B12. So there are issues like now when we look at the environment of the gut or the stomach, the environment of the gut, where we have issues dealing with hyperacidity. We also have issues like when we have the infection with parasites such as Diphyllobothrium latum, that's fish, is it dwarf tapeworm that I was talking about? This infection with Helicobacter pylori and the acid environment will lead to ineffective intrinsic factor. You see, this environment can make can be harsh, and the intrinsic factor will not operate normally. That's why I was talking about. Well, there are slides that I was showing about differential diagnosis of non-megaloblastic anemia and megaloblastic anemia, and I stated about issues leading to non-megaloblastic anemia, such as chronic alcoholism, drug consumption. There are drugs such as chemotherapeutic drugs, that's chemotherapeutic agents like methotrexate, that and also PPI, that's proton pump inhibitors. I talked about these agents that can cause non-megaloblastic anemia. In a nutshell, there are agents that affect the intrinsic factor, leading to poor absorption of vitamin B12, such as those ones I have enumerated, I've talked about. There is another issue also that can cause poor function of intrinsic factor, such as something I'm forgetting. There's like yes, there's one thing I talked about demyelination. Okay, not demyelination, because that one leads to urotube defects. There is epithelial cell lining is destroyed from the tongue downwards to the gut. What happens when the epithelial lining is destroyed? It means that even on the parietal cells, the parietal cells epithelial lining is destroyed. Now, what will the intrinsic factor do? It will bind, yes, it will bind the vitamin B12, but will vitamin B12 be effectively absorbed? No, because there are few receptors for it, because the cellular, parietal cellular lining has been destroyed. There's something that also I didn't talk about. The parietal cells are found in the gastric region, and the removal of the gastric region due to gastrectomy, that's removal of the gastric area, will lead to a very low concentration of parietal cells, meaning that absorption of vitamin B12 will be considerably low. I think Samuel, I've answered you. John Wahume, what other cell inclusions do we see in megaloblastic anemia, apart from anisocytosis and poikilocytosis? Yes, I talked about basophilic stippling. That's among the inclusions. That's one of the major inclusions we can see in megaloblastic anemia. Thank you, John Wahume. Can you post the PDFs after the presentation? Maybe I will share with the moderator, and he'll be able to assist us so that you can be able to receive the slides, the presentation. Thank you, James. On the stomach acidity, I think pH above 3, i.e. 4, 5, 6 can affect the functions of the stomach, hence leading to conditions like H. pylori, GERD, and hyperacidity. Yes, the shift in the stomach pH is very key in the functioning of intrinsic factor. Yes, and that one can also precipitate H. pylori infection and also GERD. That's why even people use PPI, those proton pump inhibitors. And also we talked about the acid environment, the acid reflux, and vitamin B12 deficiency. Yes, those things are correlated. Those elements correlate. They correlate. Thank you, Samuel. Thank you, Samuel. Yes, Chipkorir, the moderator was talking about erasing the such issues about CPDs through the platform for CPD points. I think you'll be assisted. Sorry for that, Chepkorir. Kindly raise it in the wall so that it's handled, or even a phone call to LMSK can be assisted. H. pylori is common nowadays. Can you organize a talk on that? Definitely, Lillian, we can organize for a talk. Yes, we can organize for that. Thank you for that. Thank you, Jared. Thank you, Jared. So thank you, colleagues. It's a great audience. You great people, great experts in the field of laboratory medicine and also other fields of healthcare. I really appreciate your audience. Thank you. I really appreciate. You're always welcome to LMSK for presentations and CMEs. You are all welcomed. How are reticulocyte count affected? Maybe I missed that. So sorry. Yes, reticulocytes are usually normal in megaloblastic anemia, but reticulocyte count can enable us to do differential diagnosis, to differentiate between hemolytic anemia and anemia of blood loss and megaloblastic anemia. In megaloblastic anemia, reticulocytes are normal. In anemia of blood loss and hemolytic anemias, reticulocytes are usually elevated. So that's the difference, differential diagnosis. Calvin, it's a very, very good question. RBCs are affected by megaloblastic anemia. Yes, because you see why they form macrovalocytes, because their cell membrane, the cell membrane is abnormal. And when cell membrane is abnormal, there are proteins there that are abnormal, especially the anchor proteins. We have spectrin and band3. Those proteins are abnormal. That's why they form those spherocytes. Those spherocytes can lead to vulnerability of those cells. So what happens is that when those cells are fragile because of the abnormal cell membrane, they can be easily destroyed by changes in concentration of saline, especially when they are exposed various concentration of saline. Joseph, thank you. Isaiah, thank you. Also, Miriam, thank you. Thank you. Yes. Now, this is a word from the moderator. There are technical issues on the platform on his side. So I would like to really appreciate your audience in this forum. Thank you, great people. I really appreciate your audience, and we will proceed back. We'll proceed to conclusion of this CME, and maybe what we can say is that conditions like megaloblastic anemia are important medical conditions that need close monitoring, treatment, and for us to be keen on diagnosis and also prognosis. We can easily check the prognosis of the disease depending on the picture that we see in vitamin B12, in folic acid levels, in the picture, the peripheral blood picture, in issues like the MCV, how far is it elevated, and get the level of progression and also the prognosis. So that's my parting shot, and thank you, everyone. Thank you, everybody, for your audience. May you be blessed.
Hello, Mr. Agri.
Yes, sir.
Are you able to hear me?
I can hear you.
Sorry, I think there's been a network hitch, and
Yes,
so we will be. I think you are done with the questions, the Q&A.
yes, I'm done with the questions and answers.
Okay, allow us to end it. So, to our members, to our participants, let's meet tomorrow same time for another webinar. Thank you so much.
Thanks a lot. Thanks a lot.